Onc Live Insights is a video editorial program produced by Onc Live.
In the advanced setting or in unresectable disease, the response rate to imatinib is about 50%. So in patients who may not currently be candidates for surgical resection, a neoadjuvant approach has been evaluated in smaller studies. And there's no clear data as to how long to treat patients with imatinib prior to moving forward with surgery. What we know about treatment with imatinib is that patients can have responses anywhere from 6 to 12 months out from treatment, which is different from other tumor types or other solid tumor types where we see upfront responses with the tumors and then we see more disease stability. So you can see continued shrinkage of GIST with continued treatment of imatinib. So when to intervene after offering neoadjuvant therapy, it's not really clear, but I think general guidelines or general recommendations are to intervene when the patient becomes surgically resectable. You don't necessarily have to get to the point of maximum response if the patient is now become surgically resectable because of the therapy that you've offered them. So there are smaller studies that have shown that these patients do get some benefit from neoadjuvant treatment, and I think the point of intervention is something that should be decided in your multidisciplinary team. So I think what's important about evaluating GIST is the fact that they are fairly rare tumors. So most people haven't seen many GISTs in their careers as oncologists or perhaps even as surgeons. So I think it's important to realize or to recognize that GISTs are not really benign entities where I think that category or that assignment had been made for low-risk GISTs. So a GIST is a malignant disease. It needs to be assessed based on its malignant potential, so whether that be low or high. And I think to help you clearly create a comprehensive plan for your patient, you need to have gastroenterologists that are experts at identifying these tumors, surgeons that are familiar with the surgical techniques, whether those be laparoscopic or open, to offer patients the best surgical intervention, pathologists that are savvy in terms of identifying GIST, knowing what markers to look for, being able to allow for the mutational assessment, and then oncologists who can have the discussions with patients regarding the benefits of therapy both in the adjuvant and in the metastatic setting. And then I think it's critical also to have radiologists who are familiar with reviewing these cases, particularly in the metastatic setting where typical RECIST criteria that we use for other tumors is perhaps not as applicable to GIST. And actually we're looking more to the radiologists to assess the density of the lesions on the scans as opposed to the size of the scans themselves. To have that comprehensive knowledge base, multidisciplinary approach, perhaps tumor boards that are set up in that manner, I think is really important for patients to seek out.